Hey guys, Woodruff here. Now let's jump in and talk about sinusitis. So we already talked about allergic rhinitis, which is like an inflammation of the nasal passages related to allergies. But now we're going to talk about issues with our sinuses. So the key here, because a lot of times people can mix these up, is to see, what are the differences in the symptoms that they're going to have, and then also, what's the difference in the problem. Sinusitis can get a little bit more serious. Now, this is not usually a life or death issue, but it's definitely something to consider. So this PowerPoint is a part of my longer respiratory PowerPoint starting in spring 2023 with our new textbook. I have some interactive stuff throughout this, which is what makes it a little bit different. So if you're trying to kind of see what's different about this one. So anyway, so I also have other PowerPoints that, I have longer lectures and I have other stuff that kind of has similar topics together. So if this isn't what you're looking for, feel free to keep looking. There may be something else on this channel that helps you. If not, there's lots of other great resources. So sinusitis. This is a nasal inflammation, just like in allergic rhinitis. But what happens is that it's so much swelling that it leads to a blockage in the nasal passage. So allergic rhinitis, it's more about like clear, watery drainage, just this mild inflammation in our nose. Whereas this is so much inflammation that there's a block in our sinuses, which leads to like infection and obstruction. So overall, so think, as a whole, like this can be caused by infection or caused by obstruction, but it also leads to obstruction and can lead to infection. So we talk later in cardiac about how anytime there's a stasis of anything, there's a chance for like clots and stuff like that in the bloodstream. So when there's stasis of mucus and stuff like that in our sinuses, what can happen is infection. So the same, actually, probably a better analogy is back when we get into like urinary tract infections later this semester, we talk about how when there's urine just sitting in the bladder, it's like bacteria is like, hey, look, there's that, let's go over there to that urine that's just chilling right there. So same here, this mucus is just chilling, and bacteria is like, hey, this is a great breeding ground for me to start an infection. So like I said, it might sound confusing, but I can have an infection that can lead to inflammation and cause sinusitis, but I can also have sinusitis and end up with an infection. So it works both ways. And same, I could have an obstruction, like I could have something that's blocking my nasal passage, whether it's like a physical obstruction or otherwise, that can lead to sinusitis. Because sinusitis is really just think blocked sinuses, like that's the big thing here, so that they are blocked. But what's happening here is that as a result of that obstruction, there's this mucus buildup, and it can lead to a lot of uncomfortable symptoms, and it can lead to secondary infections and other issues. So how is it different than allergic rhinitis? Overall, you want to think about those hallmark symptoms. So they can have sinus pain. So, with allergic rhinitis, there's not really pain involved. It's mostly just, itchy, watery, uncomfortable. Whereas with sinusitis, there's actual pain, and it's in your sinuses here, sometimes up in this area as well. Or kind of across here, kind of like the T-zone as they call it. So here and here. But sinus pain, probably one of the biggest hallmarks is the congestion. Usually with allergic rhinitis, there's no congestion, but with sinusitis, there is usually pretty bad congestion, really uncomfortable. They can have a possible fever, especially if infection is involved. And that's definitely one of those symptoms you want to watch. If they don't have a fever and then start to have one, it's definitely something to pay attention to. And then you have to think about the color of their drainage. So with allergic rhinitis, it was clear, watery drainage because of that allergy or allergic component to it. Whereas with sinusitis, it's purulent, because think infection. So like yellow greenish drainage. Like I said, this can lead to infection, is also a result of infection. This also can be a result of allergic rhinitis. Sometimes there can be so much inflammation in allergic rhinitis that it leads to that obstruction. So let's think, what are our priority nursing assessments? So anytime you're trying to figure out like, okay, some of these PowerPoint slides, I tell you what your priority nursing assessments are. Sometimes I might not. So you really have to think about, how can I figure these out for myself? Well, you always want to go back to your symptoms. So if my priority or my hallmark symptoms are sinus pain, congestion, fever, and drainage, those are the things I need to assess for. I need to assess for what I'm expecting, and then I need to assess for what's showing that it's getting worse. So I need to do a pain level, and I need to do that good PQRST, like what makes it better or worse, where is your pain, what number would you rate it? Is there, is there a certain time of day or something about it? What's the quality of it? How would you describe it? That kind of stuff. So I'm going to do a really good pain assessment. I'm going to assess for congestion. I'm going to check their temperature. And then I'm also going to check their drainage and look for what color it is, the thickness of it, things like that as well. So overall, an upper respiratory assessment. Now, there should be no lower respiratory involvement. I have not often heard of a sinusitis that has led to something more serious than this, but it can definitely be very uncomfortable. So biggest, secondary complication would be like another infection. So how do we manage sinusitis? Well, sinusitis can be acute, so you can just have it one time, or it can be a chronic issue. Medically, we give medications to manage their symptoms. So we use decongestants. They have really thick secretions compared to allergic rhinitis, where they have those really watery secretions. With sinusitis, they usually have thicker secretions. So we use things that are called expectorants. And we're going to go through all these meds in the next slides, just in case you're like dying to learn about more meds. We also might give acetaminophen to help with pain and fever, because it can help with both. Because remember, this is one of the first ones we talked about that has pain associated with it. So we can use things like acetaminophen, which will also help if they have a fever. And then, other symptoms, if they're having other symptoms present, like signs of allergic rhinitis or other things, we may use antihistamines. We do want to get to the bottom of the problem. But, the honest truth is most of the time this is self-limiting. And once that inflammation decreases, there's not a lot we need to do. A lot of times sinusitis is viral, so there's not a lot that we can do about it. But if the symptoms last longer than a week, they may need antibiotics. Now, we do not want to do antibiotics early for these patients. We usually try to avoid them at all cost. But if there are sometimes, like, again, if it's lasting longer than a week, not getting better, we may need to start looking at doing some antibiotics. So if the underlying problem is allergies, then we need to follow, the teaching with allergic rhinitis. We do want to always get to the bottom of the problem. If there's an actual physical obstruction, like maybe, I smashed my nose, broke my nose, and it's leading to an obstruction, obviously I would need to get that fixed. So let's look at some of these meds. Decongestants. So decongestants are meds like pseudoephedrine or Sudafed. There's also nasal decongestants like afrinasal spray, things like that. I have some drug names and mnemonics here in the second box, but how do they help? So, what's happening in, what's happening a lot of times in sinusitis is that blood vessels that are in the nasal passages are swollen or dilated. I know it probably sounds like they're constricted, but they're actually swollen and dilated. And because they're swollen and dilated, it takes up space, and that's less space to breathe. So what decongestants do is they constrict blood vessels. So a lot of these are vasoconstrictors, and they allow for more space for the person to breathe. Well, this is great because, it's going to definitely help. It can help to decrease congestion, at least for more space to breathe. Because one of the most uncomfortable parts about sinusitis is just like people say, like, oh, I can't breathe through my nose. Or they're just like, oh, it's very uncomfortable. The way I know it would work if they said, hey, my congestion's better, or it's easier to breathe through my nose. But the problem is that, again, this is a vasoconstrictor, so it can lead to problems. It can elevate my heart rate. It can elevate my blood pressure because it's constricting things. And also can have some, neurological effects that can cause insomnia. It can cause really bad excitability. So we definitely need to watch out for those possible, very serious effects. So there are some also special considerations when it comes to decongestants. So we talk about, a lot of times students mix up steroids and decongestants. So when we talked about nasal steroids, we take those daily on a regular basis for like allergic rhinitis. Those we can take long-term. Decongestants, we do not take long-term. If we take these long-term, it can lead to what's called rebound congestion, which I'm going to talk about in a second. So we only use these for a short period of time, and we need to use them as directed. So people that have heart disease, hypertension, diabetes, glaucoma, liver and kidney disease, have filter issues. A lot of people that have organ issues and blood vessel issues, filter issues, it's not going to be appropriate for them. Now, you'll see in real life people with these disorders use them, but remember, it causes vasoconstriction, which can be dangerous for a lot of these patients. So with the nasal spray, we do not want to use it for longer than 3 days or more than 3 to 4 times a day. And this goes for, it says for nasal spray, but it's for, for all decongestants as a whole. We do not want to use them for more than 3 days or more than 3 to 4 times a day, because we need to watch out for what's called rebound nasal congestion. So what this is, it's not very well understood, but it's either thought that there is like the constriction of the blood vessels, like we have these really dilated open blood vessels, and then we're wanting to constrict them a little bit, but when we constrict them, then we get so much constriction that there's less blood supply, and then that lack of blood supply leads to more swelling in the nasal passages. So it's there to help, but maybe it helps too well. There's also the thought that you could build up a tolerance, or that like if you use it for too long, that then you end up it stops working, just like anything. Since you build up a tolerance, like you need more and more and more, and so then that's why there's that rebound congestion. So it's not well understood, but as a whole, we want to be very careful. So no longer than 3 days or no more than 3 or 4 times a day. So there's also expectorants, and these you should be expecting to get stuff up, if that helps you at all. These are things like guaiacin, also known as Mucinex. It helps to thin stuff up and make it easier to cough stuff up. As a whole, we want patients to cough. We want patients to get stuff up. We'll talk about, I think when we talk about influenza, we'll talk about antitussives, which stop cough. But as a whole, we want people to get their secretions out, especially if someone's got some really yucky secretions, some infectious secretions. I want that up. I don't want them holding on to their secretions. If they have less secretions, they'll be able to breathe easier, but also I don't want infections sitting in there. So I like people to cough. So as a whole, I want people to cough and get stuff up. This does help to thin mucus as well, which helps to get it and make it easier to actually expectorate or expect it to come out. So patients may say that it's easier to cough up secretions, that they're able to cough more secretions up, or you may notice that their secretions are thinner in consistency. The only problems that people have with this a lot of times is just some of the dizziness, drowsiness. I think about the double Ds. Other things that I want to tell them is like this medication can work, but it's worked best in conjunction with increased fluid intake. So like I mentioned before, a lot of respiratory diseases, especially as we're going into COPD, and asthma and things like that, that have a lot of secretions. And we talk about it in pneumonia too, and I'm sure TB, it's good as well. It's all about, the more fluids that I have, the thinner that my, oral and nasal and other secretions will be. So this medication plus increasing my fluid intake is a great combination. Since this can lead to dizziness, drowsiness, I want to avoid other things that can make me dizzy or drowsy, like alcohol. And these shouldn't be taken for more than 1 week. This shouldn't be like a daily medication. This should just be temporarily to help with symptoms. All right, then we also talked about acetaminophen or Tylenol. Oh, look at this. I came up with a new rhyme. I made this a little while ago, so I don't remember making this. Acetaminophen will decrease your sweat and pain, but can lead to liver strain. Okay, that's cool. I'm cute. So yeah, I've always amazed myself with my nerdiness. Literally sometimes I'm like, I don't remember making these, but apparently I did. I'm sure I saw it because I remember sitting and thinking about some rhymes a little while ago. Anyway, so acetaminophen, we're going to talk about this a lot this semester. It's used for so many conditions we talk about. It can be used for mild pain and fever. So this is not usually used for patients who have extreme pain. So sometimes we'll get you on nursing school exams because we'll say like what medication's appropriate. And, acetaminophen should not be the first line if someone has extreme pain, like kidney stones, things like that. You also have to think about if people can take PO medications or not. Tylenol can be given IV, but usually it's very expensive. So usually it's given orally. So it kind of just depends for the patient, but mild pain or fever. I know that it's worked if they have less pain and or decreased fever, depending on why I was giving it. So always read in the question and make sure that you're seeing, like, was this given for a fever? Was this given for pain, or for both? Then I would be looking for both. Problems, it's hard on the liver, so we need to look at liver function, or we need to look for signs of liver damage, like if the patient is turning jaundice. That's pretty late severe sign, but yes, we want to look for those signs of liver problems. It's going to be contraindicated for those that have alcoholism or severe liver disease, and they may need regular liver function testing if they're taking it long term. They should not drink alcohol while on this medication, because that's like double liver, like it's like punching the liver twice, like saying, I'm gonna get you. All right, I'm gonna stop making bad jokes for at least 5 minutes. So, but the point is there, if you don't get my sense of humor, is just that we don't want to do anything to hurt the liver already if we're already hurting the liver with this Tylenol. All right, so my nursing focus here. My goals overall for this patient, I want to increase their comfort, promote drainage. So here's some things that we can do, that we don't necessarily need. Some of these we need an order for, some of these we don't. But also things we can tell patients at home, because most of the time people aren't coming in and they're not hanging in. I mean, I'm an ICU nurse, so I'm never seeing a patient that's coming in with sinusitis as their primary complaint. But I've never seen a patient admitted for sinusitis, but they could have this on top of something else. So it's always great to know how we can increase their comfort. So rest helps to prevent infection and allows for their body to heal, increasing the fluids like we talked about to loosen those secretions. We can also use a lot of warmth or heat. So you could do hot showers or steam. It helps to promote drainage and, helps to make it easier to get stuff out. Like I go to this one gym that has a steam room. And a lot of times if I'm feeling sick or feeling congested, I'll go there and just sit there for a while. And, it helps me. I like, at least when I'm in that room, I can breathe easier. Now, after I leave, it comes back, but it sure is some nice relief. But people can do this at home too. They don't have to have a gym with a steam room. A warm, damp towel over the sinuses can help, across the forehead here or along the sinuses, can help for pain relief. Sleeping with the head of bed elevated helps, because you have to think about drainage. If I'm trying to drain my sinuses, if I'm laying down or if I'm laying back, it's not going to allow for easy of drainage. And also saline washes. So think like a neti pot. And so we could do that 1 or 2 times per day in order to promote good drainage and thinning of secretions. And then we want to avoid other things irritating in my sinuses. So smoking, exposure to cigarette smoke is a big one. And then the signs that things are getting worse is going to be like a new or worsening fever. So if they have a high temperature, especially greater than 100.4, we'll definitely want to report that. Aside from that, it's just making them comfortable, getting that drainage out, and making sure that we're following all of those. A lot of the meds, like I said, they're only supposed to be used for a short period of time or a certain period of time. So just watching closely how often and how much they're using those medications. I think we've got a acute attack of sinusitis. All right, so let's say we have an application check. So it's always good as you're going through the content. I've had a lot of knowledge stuff so far, but it's also always good to go in and start getting deeper into application. So this is a nurse is caring for a client who has been having an acute attack of sinusitis for 1 week. Which finding is most concerning to the nurse? Okay, so it's been 1 week. They've had an acute attack, so it's not chronic. And so what's most concerning? When you see the words most concerning, here's some things to think about. Most concerning means like, which of these is going to kill the patient the quickest? Which of these do I need to report immediately, or something really severe can happen? And so like what I want to look at is that which of these is, you have to make sure that it's actually pertinent. You have to make sure that it's actually true, because some of these say like, hey, like there's decrease in SpO2. I could easily go and be like, oh my goodness, it has to be that one because ABCs. But is there actually a decrease in it, and how significant is it? Is it the worst thing out of all of these? So you could also ask yourself, which of these, if I don't report, the patient has the most chance of death or severe consequence, etc. So we have 2 sets of assessment findings here, so we need to compare and contrast. So we have one at 7 o'clock and one at 2 p.m. So heart rate 75, and then it went up by 10 points to 85. Okay. Then we have an oxygen saturation of 98%. Okay, and went down to 96%. Okay. So we have respiratory rate of 20, and it went down to 18. All right. And then a temperature of 98.9, and then a temperature of 100.6. Other findings, purulent nasal drainage or complaints of congestion. So there's a couple things in there that kind of spark my interest, but let's look at our options too. So they have decrease in SpO2, increase in temperature, increase in heart rate, and then purulent drainage. So first, I want to cross out ones that I know that it can't be. So if someone's having an acute attack of sinusitis, is there any of these that I'm expecting? And so when it comes to purulent drainage, I'm expecting that in sinusitis. So I don't think that it can be D, excuse me. D is in dog. So then I'm left with A, B, and C. So then I want to look at some of these. So decrease in SpO2. So it went from 98 to 96, but it's still greater than 95, and it's still in normal range. So I don't think it can be that one. So that leads me to increase in temperature, increase in heart rate. So my heart rate went up by 10 points and my temperature went up pretty significantly. So my heart rate went up by 10 points, but again, just like the SpO2, it's still within normal range. So I don't think that there's anything concerning there because it's only, it's increasing by 10 points, but it's still within 6,200. It's not significantly high. 85 is a normal heart rate. So the only thing that's really left is temperature, but I also have to think about like the other thing to always consider, because sometimes I can sell myself on an answer, but then I have to ask myself, is this really concerning or true? Is this something I really need to report? Because sometimes, again, I accidentally cross one out that actually is the right answer. So I always need to make sure, just because I'm left with one, I need to make sure this answer makes sense. So the patient had a temperature of 98.9. Now they're 100.6. They've had this for a week, which could mean that now if they're spiking a temperature now, they could be having like what we call a bacterial conversion, which is where they go from, they started with a viral sinusitis, but now they have a secondary bacterial infection because, that mucus that's been sitting there. So yeah, I definitely want to report that for sure, that the 100.6, because they might need to order antibiotics, especially since it's been a week and there's a new fever. So that is your application check. Hopefully that helped. And that is it for sinusitis. I'll see you for the next one.